Off again. There we go. Okay, fine. Okay.
All right, so by the way, this was a brain donated to us. This is one of my patients. He was an attorney. You know what an attorney? A lawyer. So this is from a lawyer's brain, and then a regular person. Oh yeah, and this was like a regular person, like a doctor. So you can see in America, the lawyers' brains are much bigger. Dr. Stein, did you get that? Got it already. Yeah, we'll be there in a minute.
I can't. Is the lawyer? Are these brains in formaldehyde?
Yes. Can you see it?
No. Just hold it up a bit.
Okay. I don't.
Oh boy. Okay. Yep.
All right. So, anyways, it's a nice brand. If you have time, you can take it apart, look at it, different parts, and we have a kind of a regular brain on this one. By the way, how heavy is a human brain? Anybody around? No. How many? You want to go in grams? Roughly. More than that, yeah, 1,500 or so. You have you ever seen a brain? Did you go through brain cutting? Yeah. That was very popular in the past. We used to do every week. We had brain cutting session. But anyways, you see the difference. So today we're going to talk a little bit about tremor, because it's a very common problem and something we see almost every day. And there was a nice review article in JAMA. Did all of you read this article? Yeah. Yes. Okay. Who would like to start off by telling us about tremor? Who would like to kind of mention what tremor is? What kind of tremors are there? Okay, so a tremor is an involuntary movement, right?
It's rhythmical.
It's rhythmical. Good. These are the points. It's rhythmical, involuntary, and it's a movement around the point. Like if you imagine a point, it's an oscillation around the point. Actually, everybody has tremor. We all have a tremor. If you put your own hands out, and if the right circumstances, if you have to talk in front of, let's say, many people, giving a lecture, etc., you'll find it. You have a tremor. So we all have a little bit of a tremor. But patients where the rhythmical up and downs becomes too large, the oscillations become too large, then it becomes evident. Most tremors are benign. Most tremors that we see are benign. What are the factors that make tremor worse? What are the what? Like taking like coffee, right?
Alcohol.
And what else?
Alcohol.
Alcohol. Now, alcohol. No, alcohol goes two ways, right?
Yeah.
If you have a tremor,
essential tremor,
benign essential tremor, alcohol actually decreases it.
Yes.
And alcohol was our main treatment until about 60 years ago. So alcohol, many people became alcoholics because they found that when they went to a bar and they had a shot, the tremor diminished.
Yes.
But we don't advocate that. But patients will tell you, Doc, when I have a drink, the tremor disappears. What about anxiety? Anxiety increases it, right? And tremor, how do you differentiate between benign essential tremor, or also known as familial tremor, versus something like Parkinson's disease? What are the features, the difference?
Characterized by resting tremor, yes, mostly. And mostly it starts unilaterally in upper extremity.
That's true.
But step by step it will go developing both of them.
How is the tremor different in Parkinson's disease versus benign essential tremor?
Parkinson's is a resting tremor.
What kind?
Resting.
Resting tremor.
It should
Right.
not always be rolling, but characterized, yes.
Right. One of the big differences is that Parkinson's disease, an extrapyramidal disorder, the tremor occurs at rest, right? Actually, it's worse when you take the attention away from the patient.
Yes.
And it's unilateral, just like you said. But also it has a quality to it. It's called pill rolling. Like if you're holding a pill rolling tremor, right?
It is also associated with bradykinesia, rigidity,
Exactly.
hypophonia.
Exactly. So there are all these other features, abnormal gait, usually lack of swing, arm swing, shuffling gait. It's called marche à petit pas in French. The French always had a wonderful way of describing neurological symptoms. And we can tell the difference between benign essential tremor and Parkinson's disease, but not all the time. Also, you must remember that some people with essential tremor go on and develop Parkinson's disease. But I like to be very positive with the patients. I think you've seen that. And I always kind of emphasize the good things rather than saying to the patient, well, you may develop Parkinson's disease. That's not, the poor patient leaves the office and says, what did he say? He said, well, I may develop Parkinson's. So I try to separate the two, and I'm very positive when it doesn't look like Parkinson's. What kind of testing would you do if you see somebody with tremor? What do we do?
Cerebellar tests, I mean,
Okay.
in terms of physical exam or
Right. So what we do is we take a history, right? When did it start? What makes it worse? What makes it better? Have you been on any drugs, any medications, and so forth? Very important thyroid disease, right?
Yes,
So you can have a tremor from hyperthyroidism, right? So make sure you always check thyroid disease. Anything else?
Medications.
Medications very important. And what else? Illicit drugs like cocaine or crack or other drugs that the patient may be taking. Always ask about alcohol too, and so forth. And then, so you take a history, and then we do a physical exam. We look for other diseases,
Focal neurological.
focal neurological. We look for cerebellar disease, right? We look for other extrapyramidal things. It's always good to take a cognitive test too while you're examining the patient. And in your mind, you can kind of differentiate. How about if there's a family history? Like my father had it and my grandfather had it.
They're more likely to have it.
It's more like familial, right?
Yes.
Are there any other tests that we can do? Electroencephalogram, CAT scan, MRI. Is there anything else that?
Neurological.
One of the nice things to do is to do a video. I always ask the patients when you go home and you relax, take a video of the tremor at home, and then you bring it in next time and we can look at it together. So a video is usually very helpful to evaluate the tremor. But the truth is that there's really no specific test that can differentiate. Now, when I was in residency and so forth, and a couple of the doctors were interested in tremor, we can actually measure the tremor and we can look at the height and the speed. Parkinson's disease has a slow tremor. It's like 5 to 7 hertz, right? Benign essential tremor is a faster tremor. It's a distal tremor. It affects the fingers a lot, and it's faster, right? So those are little things that can help you on the physical exam. But there's really no specific test that tells you the person has that or something else. Now, in Parkinson's disease, we do DAT, right? That MRIs and special MRIs and so forth that can help you a little bit to differentiate the movements and look at movement disorders. Therapy. What are the therapies
Essential.
The first one was myceline, primidone. How many of you know primidone, myceline? And that's a very good medication that I used in children, especially for seizures. It's an anti-seizure medication. And it came 50 years ago, 60 years ago, we were using myceline. And then in the 1970s, Dr. Young, RRY, we used to call him, one of my attendings, wrote the paper on the use of beta blockers.
Yes.
And he was a most unusual guy. A couple of months ago, we talked about him. He was you didn't want to cross him, you know, he was kind of old fashioned, some people would say mean. I crossed him, once or twice, but you didn't cross him any more than that. He didn't have a sense of humor. Have you met people like that?
Yes, I do.
It was really something. He was the world's expert on asterixis. What is asterixis?
Shaking and fluttering
yeah.
tremor.
Yeah, associated with liver disease. So Dr. Young wrote the classic paper, the review paper, and I knew everything about. So we were making rounds at Mass General. We were at the bedside with a patient, and one of the young Harvard medical students, and he didn't know Dr. Young. You know, he was on a. I was already intern resident, and he was a medical student. He said, "Did you check?" He said something like, "Did you check for ammonia?" And Dr. Young, I remember that, I looked at the guy and says, "What kind of an idiot are you?" You know, like this is the world's authority, and you know, ammonia, liver disease. That's of course, you know, of course they checked it. And the poor guy, he started crying. I had to talk to him afterwards and kind of explain to him that this is his personality. Back then, the teachers and the professors were, um, I would say, you know, they weren't very kind to students. Maybe that's a nice way of saying it. They were godlike. Not anymore, but that was an old time ago. I I got into trouble because I rotated with this man who was out. He was absolutely brilliant. Have you met people very brilliant, but the personality was horrible. Like he didn't have to be so mean. I mean, he was just you didn't cross him. I never saw him laugh or smile. Always serious. But I my it was my turn to read EEGs. I rotated on the EEG, and he was my attending. And I thought I would do a nice thing. I stayed all Saturday. I fixed up the lab. I put everything away. I'm kind of an obsessive compulsive. I put everything in order. And he found out about it on Monday, and he called me in and he started screaming at me. Who do you think you are? And how dare you come into the lab? I said, well, I'm just trying. There was no, you didn't want to cross him. But anyways, he's the one who wrote the paper on propranolol initially, one of the early papers. And he had a great interest in the tremor. So Indorol, beta blocker, is extremely helpful. But now we have other medications. And on this page here, we have a nice review. For example, anticonvulsants can be used like topiramate, Topamax, and then also benzodiazepines to relax the patient. Alprazolam has been very helpful, and even Botox, right? And Botox. Yesterday we had two patients and we did Botox on. So it's a nice thing to know because you can reassure the patients. And as I said, I'd like to have the patients leave positive rather than sad. And the biggest fear, of course, is always Parkinson's disease. They're afraid. And frequently you can separate the two and reassure the patient that this is just a benign form. You're not going to develop Parkinson's disease or dementia or something else. Anything else? Anybody want to ask any questions?
I mean, I was just wondering, is topiramate used if propranolol or prednisone doesn't work, or?
There's no set rules. I like to use beta blockers because it's safe. You check the blood pressure, vital signs, make sure the pulse is okay because it can lower the pulse rate. Sometimes it can cause hypotension. So you need to be careful that you don't cause more problems. But I like to use beta blocker initially, and I also use myceline. In some patients, I've actually used both, and I try to see which one works the best. You know, and the Medicaid, the cost is very low. They're all pennies, cost pennies. Any other questions? Good question, yeah.
Is there any reason for why the legs are less affected in essential tremor?
I think it's a good question, and it reminds me to say But many times if you check the legs, they also have a tremor, but it may not be as evident. And we don't check the legs as often as we check the arms. It's not as visible. Sometimes they also have a head movement. We've seen the other day, we had,
Yeah.
this is a yes, yes, yes movement, head to the patient. This is no, 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 no movement.
Both sides.
So there are other parts of the body that are affected, but sometimes we don't pick it up on the examination. It's just that the tremor is more evident and people tend to use their hands all the time. The feet, less so, because you're standing, you're using it, but the hand is resting. But check carefully and you'll find that the other extremities also have it. Yes. Any other questions?
Also, deep brain stimulation was very interesting and logical, but what about ablation?
Okay,
How can
yeah, that's been
explain?
used. In some patients, the tremor is so severe that it interferes with life. I think in those patients, deep brain stimulation has been considered. And I shy away from deep brain stimulation. I have a number of patients, you will see them. I'm not impressed with deep brain stimulation. It seems the people that I see are the failures. And it has soured my approach because it's complicated. You need somebody else to monitor. It's surgery of the brain. You got infection. You got the wires break. We have a patient with Parkinson's disease with deep brain stimulation who's coming in. You're probably going to see him. It was put in at the Mayo Clinic. A total failure. Shouldn't have been put in. So it was disconnected. Didn't help the patient at all. That patient, by the way, we're writing up as a case report for autoimmune Parkinson's disease. It's a fantastic idea, and I'm very much in favor that some of these patients with Parkinson's disease have a low-grade immunological condition, stimulation of various parts of the brain. And we're writing that paper with one of the students. She came from Russia, and she just sent me. We put together the patient's wife is a physician too, and really has been instrumental in looking at other treatments. This particular patient has been all over the world, including Mayo Clinic. They put in a deep brain stimulator, and when I treat him with steroids, he improves. It's quite amazing. We did it so many times. He's developed Addison's disease now. But when you treat him with steroids, not Cinemet, but steroids, he becomes kind of normal. And then when you take him off the steroids, he becomes classic Parkinson's. Beautiful study telling me that there's something else going on in Parkinson's disease, right? By the way, how many of you know about Parkinson's disease? Quite a few, right? And we see so many patients, some patients, sometimes 3 or 4 or 5 patients a day with Parkinson's. It's quite alarming to me because when I started, there was only one patient with Parkinson's a month. What happened? Anybody? Any ideas? And it's happening all over the world. China, for example, everywhere in the world. Parkinson's patients going up. Why? Anybody know?
Toxin exposures.
Is it environment, you think?
Yeah,
Environment?
it's one of the favorites.
Stress,
I feel like the aging population in general,
Okay, you think it's aging?
average lifespan is getting increased.
Not in America. The lifespan in America has been decreasing. In the last 5 years, it's been decreasing. But I don't think that's the answer. I think there has to be something else going on, maybe multiple things.
Maybe
One of
it
them
used to
is
be unrecognized.
maybe it was unrecognizable in the past, and maybe it's easier to recognize now.
Because we have
I
more
don't
tests,
think,
we have more way of finding out.
well, I don't think so because the old neurologists were very good, and they're very good in clinical observation. And Parkinson's disease, you can recognize virtually across the hall. You can just see the patient. But all of these are possibilities. Environmental, of course, is very important. The genetics, the easier to recognize.
The 10 and 10:30 are here now.
Who's here?
Your 10 and your 10:30, so someone's 10.
A 10 o'clock patient, okay. All right, well, let's go on. And I think what the other thing I want to say is that we would like to review the book. Maybe go 2, 3. Any of you have had the chance to read like the first chapter? You have? Were you able to get it on Amazon or eBay?
It's too expensive. On Amazon, it costs a fortune.
Yes,
Very
I saw
expensive.
that.
But you can get it on eBay, and you
Yeah,
can
I
get
found one on eBay.
maybe you can get like a second edition, third edition, fourth edition.
I was gonna ask you about that because I found the fourth edition and
They're all very good. I mean, in the sense of each chapter, I develop a little more and more
I'm
with
gonna see if I can
time.
get it on Z Library. That'll be free. Okay.
See if you can get it, and we can then go maybe 3 chapters every few days. Try to finish it. 19 chapters. The last chapter, I think, is particularly good because it has to do with blast injury. If any of you interested in war and explosions, and we're now seeing a lot of blast injuries, soldiers coming back, and they don't seem to have anything wrong outside, but it's all the inside. They're all in a problem. And I go over blast injuries, the different types of blast injuries, the categories of blast injuries. These are injuries that you don't see necessarily when you first examine a patient.
and I think it goes hand in hand with the psychiatric diseases too.
Right. In the book, we have a chapter on psychiatric diseases. We have a chapter on psychological diseases, neuropsych testing. A point about neuropsych testing, there are hundreds of neuropsych tests. And what do you think when there's a test, when there's hundreds of tests for something, what do you think, how valuable can it be?
I mean, very little.
I mean, if there are, let's say, 150, 200 tests, so what we call psychological tests, neuropsychological tests, you know that any one of the tests is questionable. And when I go to court, frequently the psychologists fight each other, you know, they interpret things. It's all interpretation.
Very subjective.
But we also have chapter on children's head injury, so childhood. And then we have a chapter on insurance issues as well, and social aspects of trauma, of head injury.
You got two
So we
patients
cover-
waiting for you. The
All right.
9 o'clock patient is a half hour late and she has to go to work.
Okay, got it.
Okay.
Well, was that useful, the tremor?
Yes.
Yeah, we tried to do that at least once a week, journal club. All right, so we'll see the next patient. Okay.